Okay, well, good afternoon and welcome. I'd like to welcome you today to a discussion of human experience of medical care, which we're sponsoring here by sponsored by the Franke Program in Science and the Humanities. I'm Richard Prum, a professor of ecology and evolutionary biology, and it's my pleasure to host today's event. We're excited today also to thank the Frankes, Rich and Barbara Franke, for their continued support for the program, which sponsors and fosters interdisciplinary events on campus. We have a couple of new events coming up in the rest of the month. One on Thursday, April 14th, Dr. Richard Prum will be speaking on saving culture in disaster, about cultural conservation in Haiti after the earthquake. That will be on April 14th at 4 p.m. in Sadler Hall on 100 Wall Street. And then toward the end of the month, on April 25th, we will be hosting a screening of the movie Containment, which is by Professors Peter Gallison and Rob Moss, a physicist and historian of science and professor of visual arts and design from Harvard. And this is a movie about how we should design, or how we might design, facilities to contain nuclear waste that will communicate hundreds of thousands of years into the future about the danger of that material to cultures that we can't really even imagine. So those are two exciting events coming up. I hope you can make it. So let me first introduce today's participants, starting on my right. Professor William Sledge is the George D. and Esther S. Goss Professor of Psychiatry. Dr. Sledge has served as the clinical director of the Connecticut Mental Health Center and as medical director of psychiatry at Yale New Haven Hospital. From 1995 to 2005, he's well known on campus as the master of Calhoun College, so lots of understanding and involvement in undergraduate life here at Yale. In 2013, he taught the course in the Schulman lecture class in humanities program on Freud and science in the 21st century. So as a clinician and physician, he remains interested in the classics within the psychiatric tradition. He has a passionate interest in medical and pre-medical education and is involved in efforts to develop a pre-medical track in the humanities major at Yale College. Further to his right is Dr. Lisa Sanders, and Dr. Sanders is Associate Professor of Medicine and General Medicine here at Yale. She teaches in the Family and Internal Medicine Primary Care Intern Medicine Residency Program at Yale Medical School. In addition to her work as a clinician and professor, she writes the popular diagnosis column for the New York Times Magazine, which is known worldwide to both sleuths and hypochondriacs, which eagerly await its appearance in the Sunday paper. I'm sure there's spikes in all the rare things in the weeks following her columns. From 2004 to 2012, Dr. Sanders served as technical advisor to the television show House about diagnosis and that program. She's the author in 2010 of the book Every Patient Tells a Story, Medical Mysteries and the Art of Diagnosis. And her column in the Times on Sherlock Holmes led to an interesting award from the Sherlock Holmes Society, which I think is unique here at Yale. And then all the way to the right, Dr. Matthew Ellman is Associate Professor of Medicine and General Medicine, Director of Yale Internal Medicine Associates, and Director of Palliative and End-of-Life Care Education at Yale Medical School. He has published numerous papers and has recently focused on how to teach medical students how to communicate effectively with patients about serious illnesses. So those are our panelists today. Let's give them a welcome. Great. That gives me a chance to breathe before I try to describe what we want to do today. Today's discussion will focus on the challenge of maintaining the human touch, the quality of patient experience and well-being throughout medical care. And I think we've chosen a lovely day to think about human experience, and I'm glad you all could make it. We all acknowledge that scientific medicine has made incredible progress in medical care, and that are measurable in longer life expectancy, advanced treatments and diagnostic procedures, less invasive and destructive surgical techniques, and improved public health information about what practices and habits lead to a healthy and safe life. It is safe to say that there's never been a better time to become sick than the 21st century. But practice of scientific medicine in America and elsewhere has also contributed to problems in expense, disparity in quality of care, and degradation of the human experience of medical care. Today, we want to focus on this individual experience. Many of us, of course, have many patients have experienced an increasing disconnection from medical providers, or confusion over their medical choices in healthcare, and feelings of being lost within a system. From birth to the end of life, modern medicine has achieved many great advances in human health, but there's still this gap between, or challenge, or conflict between the provision of first-rate scientific care and our experience of it. We have likely all been patients at one time or another, so rather than focus on patient testimony, I wanted to hear today from 3 experts in medical care and medical education from the medical school on this topic. So how is this going to be interdisciplinary? Well, I hope that it'll be interdisciplinary because rather than focusing merely on medical outcomes as traditionally defined, we think about this in a broader way to incorporate the human experience of that care. And I hope we can focus on what it is like to be a patient in addition to those choices. So I've asked each of the panelists today to begin or to bring today a case to present, and then we'll move with discussions and ultimately finish with questions from the audience. So I think we'll start with Dr. Ellman. And let me just remind you to bring the mic close to your face so that everybody can hear well. And please raise your hands if you're having trouble hearing. So, Dr. Ellman.
Very good, thank you, and thank you for inviting me to be here today. So we thought this case format would work well because doctors and other health professionals typically tell one another cases. That's sort of how we often spend our time talking with each other. And the format is nice because cases can be illustrative of not only the medical science in the care of patient, but far beyond that. And the case I want to tell you about, I think, is a illustration of how the practice of medicine really, from the physician's point of view, extends well beyond what we can typically understand with our science, and how humanities, in the very broad sense of the term, really informs what we try to do when we try to do what we do best when we're doctoring one doctor and one patient at a time. The case I have is actually a case of 2 patients, a couple. So I am as Rick said, I'm a general internist. I'm a primary care physician, which means that I care for patients in what we aim to be a longitudinal, continuous time over years. And my establishing relationships with individual patients is really sort of the core of how I feel I can provide the best care for them. So that's what I strive to do, is to really get to know patients in the broadest sense in order to be able to care for them the best I can, to coordinate their care with specialists. So this case is a couple who came to see me a few years ago because their physician of many years had retired. And it was a couple, a woman who was about in her late 70s, a man in his mid 80s. And when I first walked into the room, I was struck, into the exam room, I was struck by this elderly African-American couple who were dressed impeccably, really as if a lot of patients I get don't dress up to come and see me. They come in their sweatpants or something else, but these folks were really dressed very smartly, and it became clear as I began to talk to them that the man, who I'll call the Reverend because that's how his wife referred to him, was doing most of the talking. And when I started to try to speak to his wife, she really couldn't provide a lot of information, and he explained to me that, her memory in recent years hasn't been what it was in the past, and she shot right back and said, well, your memory isn't too sharp either. So I began to learn about them, their medical history. They were actually fairly healthy. He had had a small stroke a few years before that he had recovered nicely from. He had hypertension or high blood pressure, and she was actually quite healthy. She was actually about twice his size. She weighed over 200 pounds, and he was a very thin man. And I learned about their lives. He told me that he, for the first part of his life after graduating high school, he worked in construction for many years, and then exactly at the age of 45, he said he was called by the Lord to preach. And from then on, he opened up a Pentecostal church where he was the pastor for the next 40 years. He had just retired about a year ago. And she really she had had odd jobs over the years, but had also retired. So this initial visit, getting to know them, trying to establish their care, gathering records and so forth. I had them come back a few months later, and it was quite clear that her memory, her dementia was really progressing, and the family had actually called me to say they were worried that their father couldn't really care for their mother at home very well. And I brought this up to him and to her, and he insisted they were doing just fine and that nobody could care for her any better than he could. 2 months later, he came in to see me because he was sick now. He had fever, weight loss, night sweats, cough. He had an abnormal lung examination. A chest x-ray showed that was very suspicious for active tuberculosis, which required me to have to hospitalize him, to evaluate him, to treat him in an isolation capacity because he was sick with active TB. And he was quite distressed about this, only because there'd be no one at home to care for his wife. And we worked with the family to set up a plan so that family would be checking in many times a day. And he was really skeptical. He said, she's going to be in big trouble without me. Sure enough, despite all this careful planning, he had been in the hospital for a few days, and unfortunately she fell. She severely injured her knee. She became incontinent, and she needed to be hospitalized right alongside him. So I went into his isolation room to give him this news about what had happened with his wife, sat with him, held his hand, told him that she was actually right down the hall, and he was quite distressed, of course, and again explained that everything's going to be fine once he can get home and take care of her. So he recovered. He got on treatment for his tuberculosis. Eventually, was able to go home before she was ready to get discharged. And in fact, the feeling was that she could not safely go home because she was unable to walk. And at 200 pounds, it would be unreasonable for him to be able to manage assisting her from the bedroom to the bathroom to the kitchen and so forth. So we had to have her go to a rehab facility to try to get her strength back and her mobility safe. 2 days later, I get a phone call from the visiting nurse who was helping care for the Reverend at home, saying that he had been doing just fine, but when she came in, he had been in his morning bath, and she found that he had died with no warning at all, and just completely unexpected. I was shocked. He was 85 years old, but he seemed to be doing fine. I sort of scrutinized the records. Was there anything clinically that we had overlooked? And there was nothing. I spoke to his family, his children. They were not particularly surprised at all. They said that they felt that his heart just couldn't stand the anguish of having had his wife go through this, him being unable to care for her as he had been for the past 10 years. We had hoped that his wife's dementia would somehow soften the blow, I suppose, of learning that her husband had died, or that she would forget because she was extremely forgetful. So she was informed in her nursing home about what had happened, and from that moment on, for the next 6 days, day in and day out, all she kept saying is, "When is the Reverend coming? When is the Reverend coming?" And people felt, the caregivers felt, well, we don't want to keep reminding her that he's died. That seems cruel, but she just couldn't let go of this. And then on the 7th day, she woke up, got dressed, had her breakfast, and didn't utter these words, but simply passed away peacefully right after eating breakfast. I still get the chills when I think about it. But for me, again, this woman was medically quite stable. There was no sort of obvious clinical problem that would put her at high risk of dying. But clearly, she knew more in the wisdom of her dementia that she was waiting for her husband, the Reverend, to come for her. I think for me, it's illustrative, and I tell this story sometimes to medical students because I think it captures this notion that there's so much in the care of patients that we do as doctors that's medically, we can't explain with medical science, that we need to open up not only our minds but our hearts to understand or begin to see the mystery in human life. And I think bringing in sort of that broad view from art, from religion, from faith, all these things need to come to bear to really approach our patients in the best way possible. I'll stop there.
Wow.
So, Matthew, maybe before we go on, let me just ask you briefly. I know you're interested in medical education. Could you say something more about how you can prepare young doctors or doctors throughout their careers for understanding something additional to their patients' needs than just maintenance of their health by definition as blood levels and traditional measures?
Right. Yeah, I think a few things come to mind in that regard. One is that, at least at Yale, we work early in training to really encourage patients to learn their patient's story, to understand their patients as a whole person. And we do a really good job of that in the first 2 years of medical school. The real challenge has been that once students are on the wards and in the clinic, there's pressures, we can get into this more later, but there's pressures of the rapid throughput through the hospital, through the clinic. There's issues about the so-called hidden curriculum, messaging that students are exposed to by role models in different fields that may not value that as much as some educators do in the course of caring for patients in this environment that we live in. But I would say there are a couple of really contemporary trends in medical education I think bode really well for that. One is there's a big emphasis now that medical students and young doctors need to learn how to work on an interprofessional team, that they're not in on this alone, and that this is a team effort to care for patients. So one thing that we do in the palliative care curriculum is teach medical students with workshops with students from nursing, from the divinity school, from social work, to learn how to collaborate in a team effort to care for patients in a patient-centered, comprehensive way. But importantly, what this does is sort of open up or really re-energize that aspect in the medical student about issues in patient care that go beyond the pure sort of medical science. And there are a number of other ways that this is done for students. For example, we, particularly in the palliative care curriculum, and a major trend now in medical education is determining competency in medical students. So it's not enough to just have medical students take a test and know that they have a knowledge, but we need them to be able to see that they can perform these skills and care for patients in ways that we work towards. So we've developed models where we ask students to go through exercises with standardized patients who are actors portraying a patient in order for students to be able to really experiment with investigating other aspects of patients' lives beyond the pure clinical science. And we expect them to really open up these dialogues with patients, not only about physical symptoms, but about psychological, emotional aspects of a patient's life, spiritual aspects of a patient's life. And I find that this work, particularly educating about palliative care, is the ideal place to do that, and it's really applicable to caring for patients in not just with the life-threatening illnesses, but it comes to a head in that circumstance, and it's something that students learn to apply to patient care beyond that.
Sure, please.
So, in hearing that very moving story, I can't help but think that somehow...
Just closer.
Closer. How about that? Nope. How about that? Is that better? So, was she told that she was told that he was had passed away? Is that right?
She was told, the Reverend's wife?
Yeah.
Yes, she was told right away in her nursing facility. And the staff, when she kept calling for him, the staff assumed that she just didn't process it, it didn't register, or she forgot 10 minutes later.
Yeah, right. So, I mean, I'm sure you probably had this experience too, that people who are demented, they know things, but they know them differently, and they're not able to verbalize them the way they used to, or say them. And so it sounds like she died of a broken heart. She knew darn well he was gone. Otherwise, he would be there. And that was her best evidence, even if she didn't quite get the words right. And that for her, it wasn't a choice. It was just inevitable that she would go now.
I think that's how I interpret it too, and that when the staff assumed that when she kept calling, when is the Reverend coming, she just forgot that he had died and she's waiting for him to visit, but in fact, I think she was asking for when is he coming to take me, to take me away so I can be back with him.
I think that must have been what happened overnight. Is that she dreamed that he came for her, and she took care of business and went to join him.
That's how I understand it. But we don't have a diagnosis or a cause of death in our ICD code to explain that.
Well, we're working on it. Any day now, there's going to be a code that would explain.
Let's swap for the moment.
Dr. Sanders, how about your case?
So my case, I'm very interested in the individual patient who has to make themselves known, even though everything in our medical training teaches us to try and lump. We're not splitters. In order to make a diagnosis, we have to be lumpers. And that always puts the patient, really has to struggle to be seen as an individual. And so a patient I recently wrote about was this 59-year-old woman who had been for the last 7 or 8 years trying to get an answer to the question that she asked this particular doctor. She says, "Why can I not lose weight?" And so this is not an unusual question. Lots of people ask their doctors, "Why can I not lose weight?" And I think it's fair to say that she had been treated as yet another person who was trying to lose weight unsuccessfully by many doctors. She had been told repeatedly to, well, anybody here who has tried to lose weight knows the advice: you should eat less and you should exercise more. So she went to see this doctor, and she said, I keep putting on weight, I keep getting bigger all the time, and I'm in Weight Watchers, and I don't understand why I'm not losing weight. And first, as is often the case, before she saw the specialist, she saw the trainee. So she told her whole story to the trainee, which was that, you know, when she was in her 20s and her 30s and even in her 40s, she had had this very different body. And somewhere in her late 40s, she started to just explode. She just got bigger in every dimension. She said, it's not just my legs, it's not just my abdomen, my hands are bigger, my feet are bigger, my face is bigger, I'm just much heavier. And she had, in fact, gained 100 pounds over the course of that decade. And when you're confronted with a patient who fits so easily into a category, a postmenopausal woman trying to lose weight, that is a huge category for anybody who's in primary care. It's very hard to identify an individual. And she had, without really knowing that that's what she was up against, she had been struggling with this through all the doctors that she had been to. But this time it was different. Not because the doctor was different. This doctor, like all the doctors she had seen, was a very well-meaning guy who wanted to figure it out. It's not like he was just blowing her off. He wanted to help her. But something in her life had happened that made her, the next thing she told this doctor, a little bit different. Just a few weeks before, her sister, who she saw every day, because they both shared the care for their quite elderly mother, looked at her and said, "What is wrong with your face?" Which, of course, only a sister could say. You know, you could not imagine anybody else saying that. She's like, "What do you mean?" She goes, "Your face, it's so different." And she said to her sister, "You know, I thought so too. But, you know, I thought I was just getting heavier and menopause, and I don't know." So after she had told the same story to this doctor that she had told to any other doctor, she did something she'd never done before. She took out a picture of herself with her sister, and she said, "This is me." She pointed to a very attractive woman who was, 8 or 9 years younger. And when the doctor looked at the picture and then looked at the patient, it was hard to believe they were the same woman. Her face was so incredibly different. And she said, "That is who I used to be. And now, this is who I am, this giant." She told me that she thought of herself as a monster. She told that doctor that children looked at her when she got on the bus. She said, "That's not normal." And he handed the picture back to her and he said, "You're right." And I think for the first time in her entire odyssey to figure out what was wrong with her, he really looked at her, not in that lumping way of middle-aged postmenopausal woman who's trying to lose weight unsuccessfully, and looked at her as a real individual with a specific face. And she had, in fact, something called acromegaly, which is oversecretion of growth hormone, something that most people stop secreting in their own bodies, except in very low levels, once they hit puberty. We don't really, it's a very small part of who we are. But in her case, it was a very large part of who she was. And she'd had it for many years. The first symptoms are, swollen hands and feet. And she told me that her shoe size had changed over the course of 7 or 8 years from a size 8 to a size 13 WW. but that's not some information you share with your doctor. You know, I mean, we think of doctors as wanting to know a specific kind of information. So she was doing her best to identify herself as an individual with an individual problem. But until she was able to share some non-medical, I mean, how you look, is that really part of what your doctor thinks about? I mean, I didn't ask him this, but I did see a picture of her as she looked at that time. And I would say that she was sort of a homely woman. Not ugly. I can't believe that children really stared at her on the bus, but that was her sense of herself, certainly. But until she shared this non-medical information with her doctor, she couldn't be seen really as an individual. And it's the trap we run into as doctors, trying to figure out what piece of physiology, which we all share, is happening with you. Which piece of your physiology that we all share is going wrong? And seeing that makes us into lumpers. And the patient, in seeking to be an individual, has to say, no, look at me. Just not so easy. The patient's story really resonated with me because I try very hard to see my patients as individuals. But I know that I fail some of the time because yesterday I was in Stop and Shop and someone came up to me and said, "Dr. Sanders, how are you?" And I looked up at her and I kind of knew who she was. But until she said her name, I was like, oh, right. And I realized that I had failed her, as we all fail our patients every now and then because I hadn't seen her as an individual. This woman got her surgery. She did fine. She still has size 13 feet, but the rest of her is much smaller. So she had a happy ending, which is, of course, my editor's insistence that all my patients should have a happy ending.
So that sounds like the normal scientific function, the thing that the doctor wants to do, which is address the patient's problem, gets in the way of the actual science function, which is helping the patient, right? So where in the system is the loop that breaks that down, or what prevents that from happening? Because it sounds like, doctors doing what they want to do, science, apply science to the patient.
Well, I don't think that seeing people in groups is what we want to do, but it's sort of what we're trained to do. I mean, because we recognize what is normal. How do we know what normal is? Well, normal is what 95% of the population is. That's how we know what normal is. And abnormal is, specific variations. We call these diseases or disorders. And there is no single, unit of disease that is an individual specific. So it's difficult. I mean, and I think that one of the great things about being a primary care doctor, my recent failure at the Stop and Shop notwithstanding, is that we get to have relationships with our patients and we come to understand who they are in a bigger picture than the simple story that they tell us. But let me simply say, this woman had gone to the same doctor for 20 years and he never noticed. And that is common, with this particular disease, and actually with many diseases that are sort of slow accumulation. You're just used to it. I mean, if you looked at her litany of other diseases that she had, they all were common in this particular disorder that she had. But actually, they were all just common. She had high blood pressure, she had sleep apnea, she had carpal tunnel syndrome, and she had spinal stenosis. I mean, she had everything. And it's hard to see the individual sometimes. But that is the function of the primary care doctor.
Other comments?
So I think this is a great example of how the cognitive traps that we all fall into in terms of trying to make sense of an ambiguous circumstance. And anything that changes slowly is unlikely to be very well noted. And we look at the gestalt so often, and because 90% of the people we see are not odd cases. They're common cases. And so consequently, we're trying to be efficient and quick and to the point, and that's the way it looks. And something that's changing slowly, and you get used to the little features every time, you don't notice really the difference. And so that's to me, a very forgivable cognitive trap, and that's one reason why medicine really needs to be kind of a team activity where you're free and feel free to call on a colleague when something is not quite right, you don't quite see it, because you get inured to the patterns. And it is really all about pattern recognition of illness, pattern recognition of deviant behavior, pattern recognition of suffering. And if it doesn't fit a pattern, you're not likely to call it out.
Well, I think what was difficult about this patient's story is that it was something that was a very recognizable pattern. It's just it was the wrong pattern. It was more than one pattern. And even her sister, it took her sister like a really long time to go, what is wrong with your face? What a line.
Lisa, I find it interesting that, there's a lot of reasons we think about for misdiagnosis, diagnostic error, but I don't think I've heard that before, to say that the physician failed to see her as an individual, meaning really look at her face for diagnostic information. Because we do think of this condition, acromegaly, as having very distinctive features.
Well, yes.
And did she have them? She had the large brow and the large nose and the whole...
Well, so she did. First, one of the things that I didn't mention is that she's African American, and so I think the way she looked was slightly different than what we might have expected. But I think it's more than that. I think that in our brains, so all of you have seen, there are two actors who are very well known who have this disease. One was the guy who played Jaws in the James Bond movie. I don't know if any of you ever saw a James Bond movie. The other one, for people who are, in their 50s or older, the guy who played
Herman
Lurch.
Munster? Yeah.
The guy who played Lurch in the Addams Family. So both of these guys had this disorder, but they had it as children before their bones had stopped growing. So they were literally shaped by their disorder. This woman got it in her 50s, or her 40s at least. And so the changes were much more subtle. I mean, her face was very different. It was very broad. Her chin was broader. Her forehead was bigger. She had a little bit of, certainly her nose and her cheeks were broader. But she didn't look like Lurch or the guy from James Bond. She just looked like a woman who was born with a less than beautiful face. But that was not her at all. I mean, when I saw her, she was once again this extremely, attractive, symmetrical, looking woman who was in her 50s. And I do think that we struggle with the lumping instinct and our own doctoring individual care instinct. And I do think that causes problems.
Well, Dr. Sledge, your case?
Sure. I have a whole bunch of cases I'd like to talk about, but I'll just do one at a time, or one. And the business I'm in is a little complicated. I'll give you a little bit of a background. I'm a psychiatrist, and I see fairly severely mentally ill patients is my typical practice. And but I'm also a person who studies the health system in order to try to make it work better and try to find solutions to common problems. And one of the problems we have in the general hospital is certain patients get readmitted regularly. And that's a complicated kind of story. They typically have chronic physical illnesses, and they typically have bad social circumstances, and something's fallen apart, and the only way they can really cope with it is come to the hospital repeatedly until all that gets kind of reestablished. So I and some colleagues had designed a program to address that, and this program was a aggressive, active intervention that took care of a few patients who were very sick, but took care of them as outpatients. And so we had one patient who was a large woman who was obese and had hypertension and diabetes and recurrent pulmonary emboli. And pulmonary embolus is when the clot forms typically in the lower part of your body, and it goes into your lungs and causes your lungs not to function properly and can be a cause of death. And so we couldn't really understand why she was having these recurrent pulmonary emboli, but she would always get admitted to the hospital immediately when that happened. And so we had her in our group, and we were trying to figure this out. And she was very much against what we were trying to do, which was to keep her out of the hospital. And all the good things that we could give her that were alternatives to the hospital didn't satisfy her. We would help her shop. We would help get groceries. We would help her keep up with her family and so forth. And these things didn't really seem to mean much, and we were all getting a little exasperated with one another. And so we said she would call 20 or 30 times a day, telling us that, this has to be changed, this has to happen. And so it was clearly something beyond just the medical illness. And we said, okay, you can call us twice a day. You can call us once in the morning and once in the afternoon. But otherwise, we're not going to talk to you. And so save up your complaints and save up your issues. And so she was furious at this and just was threatening and profane and intimidating. But we held our ground as gently and sweetly as we could. And so finally she said, well, okay, I have a confession to make. And we said, what was it? He says, I caused my pulmonary emboli. And we said, what? And what she did, when she was feeling really bad, lonely or kind of down, she would get a piece of rubber hose tied around her legs and stop the blood flow until it clotted. And then she could tell when it was, and she would go into the emergency room and say, I have another deep vein thrombosis, I have to go into the hospital. And so, it was kind of like playing Russian roulette, because she could easily die from this, but she wasn't intending to die. She didn't want to die, but she felt desperate, because the hospital was the only place where people really cared for her and took care of her, and they all knew her name, and they would talk to her as a kind of member of the family. And when we made this revelation, and she reluctantly, but then happily, confessed that this was the case, and we made plans for a kind of different life for her. And we all were congratulating ourselves and her at the same time. Lo and behold, she steps off the curb and breaks her leg, and back into the hospital. And then we lost her. I mean, she didn't die, but she just disappeared. She went into some other system, some other way, and we lost all this kind of work that we were trying to do to keep her, to find an alternative to being sick in order to feel like she was being cared for. And it was enormously, in a way, gratifying, because we got to where we wanted to be, but we couldn't sustain it. We couldn't keep it going. That the system, or she, or something defeated us, and she slipped away from us, and we don't really know what happened. But I think that this is a story of desperation, This is the story of someone who looked to the medical system for something that was somewhat inappropriate and not quite what she needed, but the kind of secondary trappings of someone caring for you, who knows your name, who's going to help you and take care of you was what she was looking for. And she was willing to risk her life to get that under these circumstances.
How in the world could you replace that in her life? I mean, she would have replaced it if she could have.
Well, we didn't offer to replace the 24/7 coverage, but we offered her the insight to how dangerous this was, and that here are other ways that you can get people to be interested in you. And we had a lot of social services that we're going to deploy on her behalf, which are much cheaper than a hospitalization in the ICU. And so we had the system. The system was actually supporting us. They were going to give us the money in lieu of another hospitalization to support her. But you know, she went another way.
Well, let me just say that care is what we actually provide, and it was actually what she was seeking. She was just seeking a different kind of care, I guess.
Other comments?
Yeah, I'm just curious, William, what do you think sort of turned the switch where she felt safe enough to come clean with that information that she was self-inflicting these problems?
Well, so we didn't turn away from her. We didn't try to get rid of her. We didn't try to dismiss her. We listened, and we didn't retaliate with the abusiveness. We listened and said, okay, but you really needed to find another way. And it was the calls. So she was calling all the time, and we said, okay, this is not helping her. So we put this limit on it, and the limit was really what turned it, because then she began to see the kind of futility of it, and this old pattern of being sick and demanding was not really working. Mm-hmm. And we had an alternative for her, and she seemed to be willing. But the fact that she confessed her practice was enormous progress, mm-hmm. And it was incredibly defeating and frustrating to us that she had this other event then that ended up in somehow her being off in another system. Right, yeah, sucked back in, and we lost touch.
Now, each of these cases, I think, has aspects of or focuses on communication. And there's obviously in medical care, there's a social event, which a patient communicating with a doctor, and effective communication is going to be critical. Yet both sides, all patients and all doctors have biases that they bring to this situation, whether gender, race, economic, class, all sorts of things. How do doctors and how do patients address that and try to keep that in the forefront of their mind so that they see those individuals as individuals?
Well, I was talking to the patient that I wrote about recently, that I told you about, and I asked her why she thought it had taken so long for her to get a diagnosis. She said, well, I think some of it is because I'm a woman. I got put on antidepressants more times than I can tell you. She said, and I think part of it is because I'm African American. I thought that too, and I said, oh, maybe African American doctors might have been able to see this. No, she'd been to African American doctors. But it wasn't that. And she thought maybe it was because she was poor. She wasn't really sure. And I'm sure all of those things play an important role. You know, in my clinic, we mostly see poor people. So I feel like I'm sort of vaccinated against that. But the rest of it it's harder. Making assumptions. You know, this woman, people made assumptions about her because she was obese. You know, she had a BMI that was in the 50s. That's very large. And so it's hard to get past our assumptions, our lumping. We just have to work on it. You know, what can you say? But I think that patients must be aware of it as well. And they can also articulate it. Doctor, pay attention to me. I'm not just an obese black woman. I'm somebody who has a problem. I don't know. Is that too much to ask of the patient? Or maybe it wouldn't work. I don't know.
I'm interested as well, maybe before we open up to comment on another large trend in medicine, and that's the dual role of technology in both advancing medical care and the kind of treatments that are possible, interventions that are possible, but also furthering both a type of thinking and a manner of treatment that can interrupt with patient experience. So whether it's the computer screen maybe interceding between the patient and the doctor, or the battery of tests that could be run, any one of which might give information. How do we manage that challenge, besides maybe teaching doctors to look compassionately while they touch type and you know, while they go through the records? How does the system adjust to that?
Well, I think we have a huge conflict between what we can do technically and technologically and what we can do humanistically. And that's part of why we're here today, I believe. The technology is great and terrific in many ways. It allows us to extend our imagination and our effectiveness beyond anything we were able to do before. And I'm not in any way a critic of that. But the technology has with it, this is the way I see it at least, a hidden problem. It's very expensive. And the expense is, in a way, put back into the practitioners to do things more, quote, efficiently, and to become more kind of commercially aware of the way in which we practice. And talking to patients is seen as not being efficient. Talking to them in a way where you listen for a while to someone ramble on. You need to let people ramble on before you can say you've listened to them. You need to spend time that in some ways is not immediately productive for some particular task in order to be tactful, in order to be understanding, in order to know your patient. And so we have this kind of conflict, and we're constantly struggling with it. And the computer is, to me, a terrific device in terms of what it gives us is instantaneous information. We would usually have to go days or sometimes weeks to get, and you can just dial it in and there it is. That's great. But to the extent that it takes you away from thinking about the patient in a narrative way, in a story way, and think about how you document that in a way that's going to be useful to others, it's a real problem. And so, consequently, there are not real easy solutions to that, but I'm convinced that we'll work it out. And I've studied other systems. I mean, again, as a health services investigator, I've spent time in the UK and Canada, and I see how, and a little bit in Germany, and I see how other systems try to solve these problems. And I'm sure that there are solutions, but we have a very strong vested interest class in the form of the commercialization of medical care, mostly through insurance. And our insurance is like nothing else in the world in terms of how it works. And it really creates a kind of sclerotic quality about what we can do and what we can't do. And we have to be can't let the insurance business run medical care. That's my point.
Yeah, I would extend that. I mean, these are probably the most important, some of the most important things in where we are historically in the practice of medicine. We don't really know how to deploy the technology in the best way. And I'll give you a simple example. So it seems like you have, for example, a patient might come to see me with back pain and sciatica. You would think the most efficient thing to do is get an MRI scan of the spine. Let's see what the pathology is, look at the anatomy, and we'll know how to best handle that. Certainly, there are sort of perverse incentives in the way medicine is paid for that it's a lot more efficient for and profitable for the health system in certain ways to bill for an MRI scan rather than to pay a physician to sit and carefully listen and examine a patient with back pain. But that MRI scan is really going to be problematic in many circumstances in knowing how to treat the patient. There are many studies done that show that 50% of adults who are walking around feeling completely fine without back pain, if they have an MRI scan, it'll show these huge bulging discs that look like they're pressing on nerves and need an operation tomorrow. So certainly in order to know what's best for a patient, you need to correlate what's on the MRI scan, if you choose to get it, with the patient's symptoms and physical examination, or else you're going down a road, and this has happened to a lot of patients who've had, I think we're wiser about it now, but who have had back surgery that really didn't end up helping them because it was driven by the imaging test, by the technology, rather than by a careful interview and physical examination. So I think we're really at a fascinating time in terms of medical care. We can't go on like we are now. Everybody knows that the system will go broke, and people are not getting healthier because of it.
I think not only is the system broken and we can't afford it, it's not really what people want. Sometimes people say, oh, my doctor didn't get the test I wanted. But I think more commonly, people say, my doctor didn't really spend time with me, didn't really hear me, didn't really talk to me. And we have studies that show that that is actually the case, that when doctors and patients are interviewed after an encounter, they often think that different things happened in this very brief encounter. Their version of what happened and the other person's version of what happened are not the same. They just don't spend enough time together, and certainly not enough quality time together. And the computer, of course, in some ways makes that much, much worse. We have to figure out how to value what really matters in medicine. And what really matters in medicine is the relationship between the doctor and the patient, actually listening to what the patient has to say and examining them, and then based on that, figuring out what is the most likely problem and then testing for that. Shooting people in the face with a kind of a diagnostic shotgun, which is what an MRI is not useful. It turns out not to lead us to the right answers. But doctors feel compelled to do that. Time makes them feel like they have to do it, and this sense that they have to give the patient this concrete answer of something that is verifiable. I don't know if maybe you do need that. I'm not sure. As a patient, I don't need it, but perhaps other people do. But I think that both doctors and patients don't really recognize the value is something that isn't encased in metal. The value of what happens is what happens in that room.
Well, great. Maybe we'll move to questions. I think we have microphones, so anyone who would like to ask a question, you can meet in the aisle, or you can. Question? Yeah, go right ahead. Oh. Right there.
Thank you.
Yeah.
I'm a bit staggered as I listened to the case that was described that you essentially lost any contact with a patient because you don't know where she is. With all the technology and the wonders of Epic and so forth, did anybody think of starting to look at the census death index as this patient passed away?
Well,
Where's the logical tools that you have to overcome the bureaucracy that's in your way?
well, so this was a pre-Epic case, but even with Epic, I mean, I know Epic, and it's not hard to lose patients. And the death index is very difficult to use. You can't just dial it up and figure out if someone died. You have to have a reason for it. And the government is not eager to give that to you. But it's not really helpful because when patients get lost, it's usually because some family member has come along and taken them in who's never been known in the system, and we have no way of finding that person. So in her case, she stepped off a curb, broke her leg, went to another service. We asked them to keep us informed when she was about ready to go. They didn't, and we had no idea where she was. And she was not at where she used to be. So she went somewhere else, a friend, maybe a relative we didn't know. We couldn't find her. But she didn't come back to. She also had the option herself to come back, and if she was, unless she was in another town or whatnot. So we did what we could do to try to find her, and she wasn't. She was lost.
But was she not in principle, a clinical trial?
No, she wasn't.
She was contributing to your growth of knowledge?
Oh, she was clearly
It's lost.
contributing.
You have no view of her.
I'm sorry?
You have no view of her now.
No, true enough.
Yeah, next. You had a hand up there. Yeah, there. Ty.
Thank you. I was stunned at your talk about MRIs because I've just been through that and with sciatica. And as luck would have it, I ran into a doctor from public health at Yale, and I was talking about impending surgery. And he said, well, I was going to be a surgeon, but he said, I decided not to because I want to deal with the whole person. And the surgeon that I was going to have and canceled was terrific, best there can be. But I just wonder if you could comment on the difference between the way surgeons may approach and use their skills as compared with other doctors or general practitioners.
Well, I think that in amongst people in the medical field, it's a bit of a stereotype. I've certainly, I know a lot of surgeons who expertly and compassionately treat the whole person, and some who don't, and also for non-surgical physicians. But there is a bit of the, you know, if you have a hammer, you're a nail. If you go to a back surgeon, presumably you're looking for help, and they might offer you a surgery. Certainly there are plenty of surgeons who would counsel someone to, particularly for back surgery these days, to sort of give it some time and see if it gets better without an operation. Now I don't know your particular situation, but I think in areas where outcomes are not quite as cut and dry as we had thought, there's a bit more caution for that type of surgery. I had a back trouble too with a disc, and I didn't even want to get a scan personally because I just didn't even want to know what was there. I just wanted to see if I would get better without it with some therapy. It's my own personal story, and I did. I think people have different feelings, as you alluded to. What they want to really know exactly what's there, and many people don't. But I think that's a bit of a stereotype. I don't know how you folks feel about that distinction between surgeons and non-surgeons in terms of treating the whole patient.
It seems to me that surgeons have to be very good at assessing people in a lot of different ways and really quickly. You're about to let somebody cut your body open and mess with how your body works. That really requires a tremendous level of trust. And I think that surgeons must be very good. They have to be very good at helping people feel that trust. Now, sometimes they do it with the compassion versus competence model. Those who are, I would say, socially deficient, say, I'm incredibly competent, here are my numbers, and like House MD, we don't have to be, we can just dispense with the social niceties because I'm the best. So that's one way to do it, but there are only so many best surgeons. I think that there are a lot of surgeons who actually have a skill at understanding what people are concerned about and reaching out to the whole person, at least the whole person's brain, if not their entire body. So I don't think that most surgeons everybody who subspecializes is not interested in the whole patient, kind of. They're interested in this aspect of the whole patient. I think as a primary care doctor, I am involved in the whole patient, but probably there's somebody who could say something that's not really the whole patient either.
Any surgeons in the audience who want to comment? Spouses of surgeons.
I would like to say a word on behalf of surgeons. I went to a surgical medical school, and I had exposure to some of the leading lights of surgery in the history of American medicine. And I was recently operated on in a 7-hour operation that was only 5 weeks ago, and I'm up and now I can walk around. I couldn't even barely walk before. And I have a great deal of regard for this ability to be so technically proficient and at the same time having even just a modicum of human grace. And almost all the surgeons I know are interested in getting along with people. And they have different views of how to do it, maybe, from one to the other. And sometimes they may be a little offensive, but for the most part, they're remarkably adept. I'm a great fan of surgery, and particularly when it's done, when it has to be done, as opposed to part of our system rewards the wrong things, and I think that's one of the values of this new healthcare system we're facing, is it tries to get away from that system of reward. Instead, rewards efficiency and effectiveness and good outcomes. And so we're going to be paid as physicians more for what we don't do in the future than what we have been doing. And it's going to be more a system of looking ahead to what are the things that make people healthy and what are the things that make people prosper. And it may be a long time in coming because there are a lot of entrenched needs and interests that are going to make that hard to do. But I think the vision is pretty clear, and I think it's one that can be sustained. Now, I know enough about the healthcare and other parts of Western civilization to know that it does happen there, and there's affordable care that's done very well and very humanely. And the UK is one place. The UK has a remarkably better health outcomes for their population than we do, and they spend a fraction of the amount of money that we do. Now, it's not a glorious system. I mean, it's not brand new. There are not a lot of shiny hospitals, and you don't have the kind of wealth among the the class of people who are providing this care, but it's very steady, efficient, and effective. And that's part of what we need to look to and to embrace, is a different way of getting care and a different way of taking care of ourselves so that we don't need as much care. And so I'm thankful for surgeons. I'm thankful for the technology that was applied to my body 5 weeks ago and allows me to stand up and walk around now in a way I couldn't do. But at the same time, I know it costs a fortune, and I know that this can't go on, and we have to find other ways to solve these problems.
But thank God it lasted long enough for you to be able to walk again. I'm glad to hear that.
Next,
Glad you're glad.
Another question?
We may need to assume some of that stiff upper lip attitude to when the doctor tells you, nope, that we're done with that.
Well, so that's a good point, because that's what that's what happens in the UK. People have to wait, and they don't get access to discretionary care right away. You can't walk into a doctor's office and say, I need an MRI on my back, and expect it to happen. And
Right here.
I was amused to hear your comments about MRIs. I remember when trying to learn to use software for analyzing brain images, and to my surprise, discovering these are not pictures. This is very highly manipulated data that people think are just pictures. But I was attracted here by the subject of the patient's experience, and I was very reassured to hear you all talk about the doctor's experience of the patient ranging outside your usual decision tree. But I asked Mark Mercurio of Yale New Haven this question several years ago. Do we really know how patients are experiencing being in the hospital? And I know there are these little forms here and there, and he said, do we really have data? Not really. And I'd like to re-ask the question whether that's changed, whether, people like social psychologists have been quantifying what's going on so that we have more than very attractive stories about interchanges.
So working in a hospital where the bureaucracy is heavy and focused on a variety of things like this, there's been an earnest, but I wouldn't say effective, effort to try to get at the patient experience. But because it is earnest, it will persist and it will eventually get it right. And there's this large organization called Press Ganey, which is a surveying group that has a lock on the industry and has all these kinds of measures and so forth. And the Press Ganey CEO was recently at Yale New Haven, and I didn't hear him say this, but it was quoted to me by a variety of people because they know how I feel about Press Ganey. He said, forget what we survey. It's useless because the way we do it is not in any way scientific. What we look for are the things that people write in on the margins, the things that they say in their own words, not the way they answer the questions that we've come up with. And it's those qualitative aspects that really tell us where should be telling you, talking to us, where you should be. And I believe that to be true. I do health services research all the time, and I ask hundreds of people these questions and so forth, but nothing beats a conversation. And we're getting better at having efficient conversations where we can really figure out what's going on with people's experience. And the experience is key. And there's some terrible things that go on in hospitals that around patient care. And it's not ever all easy. And we have to be humble in the face of these data that tells us we're sometimes acting like heartless people. We're not being careful enough. We're make too many mistakes. We don't show consideration. And I was recently on a surgical service, and I've never had such an experience. I've been in the hospital a lot. That's one reason I'm a doctor. I mean, I've never had such an experience of a nursing group that was so well trained to treat me like a person. I was very touched by it, and I was impressed. It's not that way throughout. You can't count on that always, but it's happening, and I think it's changing, and I think there's more and more administrative and fiscal focus on these kinds of issues.
The other driver, let me make one brief comment. The other driver that's caught the imagination of our hospital administrators is that there's now money on the line, that 2% of Medicare payments to hospitals is going to be at risk in both directions based on not only patient clinical outcomes, but patient satisfaction. Granted, it's limited to survey data, but that's also driving a kind of heightened interest and making this a more robust effort, at least at Yale New Haven Hospital, to really seek out and improve the experience of patients in the hospital.
You used the word time. Is there a limitation on the amount of time that you can spend per patient? Because the narrative stories that you're wanting and do here takes time.
Actually, that's been measured. How long it takes a patient to tell their story. If you just say, what's going on? And then they say, I have this pain in my knee, or whatever it is they talk about. And those stories almost never go over 2.5 minutes. So, yeah, it takes time, but it doesn't take as much time as I think that doctors fear. I think that doctors do feel this time pressure. I don't feel this time pressure because I have the luxury of having an academic practice where I get an hour for new patients and a half an hour for return patients. It's an incredible luxury, I guess. Certainly,
I would
feels
like
that way.
Can I add something to this? Because this is, to me, a wonderful place to be talking. So if the doctor is under pressure to not spend more than 15 minutes, then they never get it done right. And because you feel like you've got to control it, and you've got to organize it. And when you start pushing patients into a situation where they have to answer these questions in this order, in this way, you don't get good information, and it takes forever. If you do what Lisa's talking about, which is figure out how to listen carefully and ask the right questions, you'll get a wealth of information in a very short period of time, and the patient will feel like they've been listened to and that you understand them. And those are very important outcomes to have. And we haven't discovered this well enough yet. We will. We'll get there. It'll happen.
You're such an optimist.
I am an optimist. I am an optimist.
One more question, I think you got.
First of all, I'd like to defend the surgeons, and I think that people forget that they're specialists and they're not general doctors, and the patient comes to you with a diagnosis from the internist so that you are focused down on what the patient has, and it's usually something that you hopefully can fix, so that it's a different sort of approach than, say, a primary care doctor. Now, the other
Thank God.
The other thing I want to raise was the fact that this time business that Mrs. Frankie raised, and it is no different in Britain than it is here. I was in the doctor's office in Britain 2 months ago, and it has a notice up which says, you have 10 minutes and you can only bring up 3 subjects. There's a notice in the waiting room which says that. And the way your appointments are fixed. They're only 10 minutes, and you have to go and leave after 10 minutes, and you can only raise one or two things. And if you have something else, you have to make another appointment. It's the same here. Most doctors are pressured for time. They have a waiting room full of people, and they have so many minutes. They have to keep going to see everybody. What you have is a tremendous luxury in academic medicine. In outside practice, most people are beating the clock all the time.
Why is that?
Well, because that's the way the system is arranged. You can't make a living unless you see a number of patients. And that's the problem.
So
if you're paid on a salary.
Yeah.
But in England, they're paid on a salary and they have the same problem.
Yeah.
Well, let me give you an alternative model, because I've seen it in action and I really loved it. And I hate to say where I saw it. It was in Boston at Harvard. And I was, what was I doing there? I can't remember it exactly at the moment, but I was visiting a urology service clinic. And I was trying to get some sense of how they operated around issues. And it was, so they had a clinic where it was just a mill, where routine care happened like in 5-minute intervals. It was just, they just ran people through it. And it was routine. Then they had a clinic where it was not routine, where it was a complicated thing. It was cancer of the prostate, and it was when the finding was there was a tumor on the capsule, and what to do. Do you do radiation? Do you do surgery, extirpation, or do you
Nothing.
or just wait? and so what they did was they'd have a conference that lasted an hour and a half per patient, where the patient and the patient's wife would be there, and each of the services would present their proposal for treatment. And the patient would make the decision along with the wife because of the sexual dysfunction aspects that were side effects of some things and not the other. And to me, it was the most astonishing display totally of how this clinic was so well organized, so that the routine things where you didn't need to spend much time just got taken care of, and that funded this very expensive show of at least 4 different services making a presentation to a patient and his wife about what to do. And it was remarkable. And we can do this. We can do things like this. It just takes imagination and clarity about what it is we're trying to do.
Wouldn't work for the lady with acromegaly.
One last question, or I guess we got 2 more, so we'll keep them going as long as. Yeah, go ahead.
The patient is on a journey, and it's life's journey. And the patient sees doctors, and the destination, which is a word we haven't used here today, is this thing called death. And the patient is putting themselves into the hands of our medical system. And they're looking to the doctor for some solace and some sort of broader view of what this next step is. And it gets more serious and more isolated as the patient goes on. And if the patient and if your systems are successful in curing disease 1, then the patient lives a few more years, and then disease 2 comes along, or situation 3 comes along. So Dr. Sledge is replaced by another person, and another person and another person in the process who are new to that patient. So what does the patient's journey is a long and very personal journey. How can we make that better?
Can I just put in a word for the primary care doctor who should be traveling with the patient, through their medical experiences? So many patients who write to me and saying, oh, I need a diagnosis, their primary care doctor, they have left behind so many years ago. They have nobody who's keeping track of what their questions are or the answers they're getting back. So it's true that every patient has their own journey to take, even though we all end up at the same destination. I would just like to argue for having a doctor who you trust and know be part of that journey with you.
Let me also add, first of all, it's an issue if the patient keeps outliving all their doctors, and they're gone one after another before the patient. I'm being a bit facetious, but I think what you've captured, Rich, one point I want to highlight is that what the physician really, there's the technology, there are the treatments, there are the cures, but what I see as what the experienced physician really has to offer is what you alluded to, which is being able to help the patient understand what the realm of possibilities are, what life will be like in the next phase, to be able to anticipate because they've seen it before with other patients and because they've lived it with other patients and hopefully accompanied them on that journey. The question is, how do you sort of, as you posed, how does an individual patient retain their personhood when they're faced with one physician after another, or how do they convey that enough that there's a feeling that this physician is on that journey with him? I don't have the answer to that. I think that's what an individual tries to do with patients that they've known for a long time. But in today's medicine, where if you have a serious illness, you often have a whole cadre of physicians who may or may not know you for much time at all. The very good specialists that I see are able to very quickly understand a patient as a person and be able to tailor what they need and tailor their expertise for that person. How do we capture that and sort of make sure that happens uniformly? I don't have an answer for that yet.
So, I went to Cuba a while ago. I'll do this one. I went to Cuba on a different kind of trip, but it had a medical side to it. And I peered under the hood of the Cuban medical system. And this is a system of care that lives on fumes. There is virtually a small fraction of the amount of money we pay per person available to them. And yet, it is remarkably effective. And one of the things, and a lot of reasons for this, but one of them is they get so many people involved in it in so many different ways. And there's such a clear cultural and society endorsement of what they're doing, and they're all on board. And so part of that is the living better and eating well and exercising and things like that. But it's also a system of caretakers, some informal, some not, who provide that comfort and solace. They don't have a whole lot of doctors, but they have enough to get the basic health taken care of. It's just a remarkable place to see, and I think anybody who's interested in how all this works ought to go there and spend some time and see it in action. It's not a myth. It's not a fiction. It's a real societal focus on health.
Yeah. Well, we have the third last question. One more question there. Thank you all.
I'm going to try for 2 half questions, so you can take your pick, but I'll try and make them brief. One of them is the role of the physician's assistant. I'm wondering how a sort of a 2-level approach in a doctor's office is going to upset or enhance the actual doctor's experience of the patient as an individual. That's one question. The other is the advisability of aligning yourself as a patient with a medical group as opposed to individuals. You've spoken very strongly about the fact that it's good for the physicians to feel that they're not alone with this patient, that they have company in decision making. But I'm wondering, from the patient standpoint, one often is suspicious that you'd be better off being able to choose your specialists. So those are the 2 half questions.
Responses.
Well, let me address your first question about physician's assistants, nurse practitioners, because this is ubiquitous in today's practices. And I'm of 2 minds. One is that I think this is probably the answer to a lot of the ills of the electronic medical record, where there's so much task-driven work to do that the physician is occupied in these tasks, in this documentation, that we need to be smart enough to enlist other types of staff and clinical staff to unload the physicians from all those tasks in order to get them back to the patient face-to-face and really prioritize that time. On the other hand, I know from my own practice for 20 years that, and we have our particular practice at Yale is very light on mid-level, so-called mid-level providers, and people want to see their personal physician if they're really sick in any way, or if they're really concerned about their health. If it's for a minor ailment, most people are satisfied with getting a treatment from an advanced nurse or physician's assistant, but I hear time and time again that people just really want to see their personal physician. So I think it's a big challenge for the system, and we need to be smart about how to deploy that in a team way, in a team-based way.
Last comments?
Well, it's inevitable. It's the only way we can really bring it off, is to have a variety of people at different skill levels who have different functions. And a team, it's a team. It has to be a team. And there are not enough practitioners to go around, and there won't be enough. And they cost too much. And so it's QED. That's what it will be. And in every place I've seen where that's the case, it works well. It works very well. And I know for myself, you go to the dentist, and my main focus is on the dentist hygienist who does the most work and spends the most time with me, and the dentist comes in and does something that looks, and but I'm fine with that. Personally, I mean, I know that if something really bad, it'll get bumped up to another level of expertise. I didn't quite get the last question you had. The second half question was, well, just can you, yeah.
The idea of working with a medical group of physicians rather than choosing this, and that specialist. But it's interesting because what you're saying essentially is you can get the group effect vertically as well as horizontally.
Right. So horizontally and vertically, that's
so
right.
Those half questions do sort of relate to each other, I see now.
Right. Well, and I think the idea of group practices is a very efficient one. And I mean, I haven't functioned in those. I've always lived in the academic world, which is a big, giant group practice, basically. And so
one plug for group practices is that when you look at what doctors know, which in this day and time is so important because knowledge is expanding so rapidly, doctors who work, or providers, I hate that word, but you know what I mean, doctors and nurses and PAs who work in group practices know more than doctors who work alone. And so I think that there's a lot of reasons to be in favor of a group practice.
Well, thank you very much for coming, and let's thank our panelists.